Hi friends. So in this video, we're going to be discussing the approach to a chest X-ray. It is the most basic thing that every radiologist has to know, every resident has to know, every first year resident is also expected to know this no matter when you joined. So this should be the first thing that you are seeing in this module. Now, when we talk about the chest X-ray, why it is something which scares most of the residents is because anytime you've been given a case of any mediastinal mass or any chest pathology, you know how your viva is going to begin. You are going to have to describe the chest X-ray. You're going to have to describe the technical parameters, and that is where most of the times, the examiner is going to trap you because they're going to ask you different parameters of assessing the adequacy of a chest X-ray, and that is how every viva starts. So this is where you have a very good chance to actually impress the examiner and set the tone of the entire viva, because if you do this part well, then they know that you know stuff. So this is something which is so important and underrated that way. So that's why I want to start with this particular video up front, so that we know what we are doing when we are given a chest X-ray. And this is something not just for the exam but for life. It is one of the most commonly used investigations. And if you report chest X-rays, if you report X-rays in your practice, chest X-ray is going to be the majority of them. So this is something where we just can't afford to go wrong. So having said that, let's now begin with a systematic approach. So this is going to be very important for the exam, that you say it in this order. It will be something that really gives you that edge if you go in this order and you mention, because the examiners will know that okay, you're thinking in this direction, right? So this is how you set the tone. So whenever you're starting off, you start off with the patient age, the sex of the patient, and what the patient presented with. So you tell the history and examination findings, if any have been given. Second most important point, which frequently we tend to miss out, is here, which is old imaging. So if there is any old imaging, you mention, but what is going to give you these brownie points is you mention that no prior imaging has been given to me. Do say this line. Believe me, it is going to be very, very impressive, because they know that you've been thinking about it, and it's very imperative that you compare previous imaging of any given patient. And this is a line that you should have in your system, that when you're starting off your case, you're saying the clinical features, you're describing the age and gender, and then you say this line, that prior imaging has not been provided to me, right? So these are subtle points to score really well in your vivas and your long cases. This is what gives you a good start. So after that, again, something we tend to miss is you talk about the view. So let's say you've been given a frontal chest X-ray most commonly. So you say that it's a frontal radiograph or a lateral radiograph or a lateral decubitus radiograph. One of these would be given, most commonly frontal. Then you talk about the view. So you say whether it's an AP view or a PA view. If it's not been mentioned, we can safely assume that it's a PA view. If it's an AP view, it would be written on the film, right? So AP versus PA view. And then you start off by talking about the technical parameters. The three technical parameters that we need to talk about, you can remember, RIP, rest in peace, or no particular order, inspiration, rotation, and penetration. So these are the three things we have to talk about. So this is what you start off with, right? So now I'm going to talk about the details of all of these things, about AP versus PA, inspiration, rotation, and penetration, and how we assess whether it's adequate or not, and if it's not adequate, what difference will it make to the image. So this is what we start off with. So let's start off with the view. So the ideal view that we want is a PA view, right? Most commonly, this is how we acquire a PA view, where the X-rays are passing from the back of the patient to the front of the patient, and it's the anterior chest wall which is in contact with the image detector. Why do we do so? Why do I ideally want a PA view? The answer to that is because whatever structures are closer to the detector are going to be equal to their real size. They are going to be closest to their real size. Other way of putting this is, in a PA view, the magnification of heart is going to be minimum. Why am I doing a chest X-ray? It's not to see the mediastinum, it's not to see the heart, it is to assess the lungs. So I want the heart to be less magnified so that I can see more lungs, isn't it? So this is why I want heart to be minimally magnified, and that is why PA view is better. Again, what distance do I acquire it from? So the source to image distance is going to be 180 centimeter. Why 180 centimeters? The other X-rays are acquired from 100 centimeter distance. Why 180? So this distance, this larger distance ensures that the parallel beam X-rays reach the heart. Because these are parallel beam, they are non-diverging, that ensures that there is no magnification of the structures closer to the image detector. That's a very important point, right? So your question for the, especially for the first year JRs, whenever you're given a chest X-rays, why do I take a PAView? And there your answer has to be, you say that, sir or ma'am, the heart is closer to the image detector, and that is why it is going to be closest to its real size. In one line, I can say that there is reduced magnification of the heart so that we can see more lungs. I hope this concept is clear. If they dwell more, if they ask more from you, you can talk about the distance 180 centimeter, and you can say that the beam is non-divergent, right? So this is our learning point here. So this is how a PAView will appear. So now let's understand this further, that when I take an APU, let's say there's a trauma patient, there's a patient in an ICU who cannot get up and give you a PAView. So there I have to take an APView. So now see this, the distance is shorter obviously. So what will happen is there is a divergent beam. So here what you have to understand is there is going to be a divergent beam, and heart here is anterior. It is not closer to the image detector, and that is why there is going to be more magnification of the heart here. Okay, so this is what we understand here, that the distance between the source to the image detector is shorter in an APView, resulting in a divergent beam, resulting in more magnification of the heart. So now let's look at the resultant image, resultant chest X-ray. So here you can see how the mediastinum, how the heart appears wider. So what you have to remember, on an APView there is apparent cardiomegaly. So you cannot comment on the mediastinum, you cannot comment on the cardiothoracic ratio or cardiomegaly on an APView. That's the only thing. And you can see how the visualized lung fields are going to be smaller here, right? So the same thing. So this is PA versus APView and the difference that it makes. Moving on to how do I assess inspiration? Again, something that will be asked to you is theory. So you have to just comment whether the inspiration is adequate or not adequate. So what do I call as an adequate inspiration? So for an adequate inspiration, what I need is to count the ribs, and I have to see at least 6 more than equal to 6 ribs anteriorly, or more than equal to 10 ribs posteriorly in contact with the dome of the diaphragm. So here till this point there should be at least 6 anterior ribs or 10 posterior ribs, and that is what we call as an adequate inspiration. So we'll be talking about counting of ribs as we go along, but just as a preliminary, what you can see here, so I'm just gonna count in real time for you. So this is my pointer. So this is the first rib, the second rib, this is the third rib, 4, 5, 6, 7, 8, 9, 10. So I can see that there are 10 ribs posteriorly. When we look at the anterior ones, 1, 2, 3, 4, 5, and 6. You see the 6th anterior rib crossing the dome of the diaphragm, and that is how I know that this is adequate inspiration. On the other hand, look at this one here. So 1, 2, 3, 4, and 5. I see that the 5th anterior rib here is crossing the dome of the diaphragm. Let's talk about the posterior ones. So I can see how 1, 2, 3, 4, 5, 6, 7, 8, and 9th posterior rib is crossing the dome of diaphragm. Hence, I can say that this is not adequate inspiration. The question that will be put to you is, what difference will it make? If it's not adequate inspiration, why do I need an adequately inspirational film? 2 points you have to remember. The first point is going to be, again, in an inadequate inspiration, 2 things you have to remember. The first one is, again, you can see how there is apparent cardiomegaly. The heart shadow looks bigger, the mediastinum looks bigger. So first is apparent cardiomegaly. In fact, if you forget and you don't know the answer, you can just shoot with apparent cardiomegaly, in most cases. So first is apparent cardiomegaly. The reason behind the apparent cardiomegaly, if you just want to know, the concept here is going to be whenever you take an inspiration, the diaphragm contracts, yeah, so the diaphragm pulls the heart down with it. When there is no adequate inspiratory contraction, the heart stretches out on the lateral dimension. So that's the concept of why in inadequate inspiration there is apparent cardiomegaly. Now, but the second concept is, because there is inadequate respiration, what will happen is the basal vessels are going to be crowded, right? So what I'm going to see is, because of the lack of the lung expansion, the vessels at the bases are going to be crowded, and that might simulate an infection, or sometimes it might simulate a basal collapse, right? So second result is going to be crowding of the vessels, particularly happens at the lung bases, which may simulate segmental collapse, subsegmental collapse, or simulate an infection, right? So this is what we need to know about adequate inspiratory effort. Moving on now to penetration. So penetration is something that you subjectively only can say whether it is adequate or non-adequate. For the exams particularly, how do I decide whether it's an over-penetrated or an under-penetrated film? So adequate penetration is defined when I can see the lower thoracic vertebrae. So if I can see the lower thoracic vertebrae through the heart, yeah, so this is the heart shadow, and if I can see the lower thoracic vertebrae through it, that's a adequately penetrated film. So lower thoracic vertebrae through the heart. Yeah. Now, what is an under-penetrated film? What is an over-penetrated film? You are seeing here. An under-penetrated film is when I cannot see the spine shadow through the heart. Yeah. So here in an under-penetrated film, I cannot see the spine through the heart. Yeah. So very obvious. Once I know what is adequate penetration, this becomes very easy. So no spine through the heart. What is an over-penetrated film? So here you can see how the lung feels. Everything is so hyperlucent. Everything is so black. So this is when, how do I define, or what is the definition of an over-penetrated film, is when you can actually see the IV discs through it. So look here, you can see the IV discs also. So this is something which is a sign of over-penetrated X-ray. So over-penetrated X-ray is when IV discs can be visualized. All right, so these are the definitions of an under-penetrated, over-penetrated films. Moving on now to something very important for the exam. So this is rotated film. They ask you a lot of questions here. So first of all, how do you assess rotation? So rotation is assessed by seeing the spinous processes. So these are the spinous processes. So spinous processes of T1 to T4 vertebrae you assess with the medial ends of the two clavicle. So here you can see that the distance is higher on the right side as compared to the left side. So basic things. Which side is this X-ray rotated towards? So again, let's see in this schematic diagram, good diagram. So first of all, here you can see that the left medial end of clavicle is farther away from the spinous process than the right side. So whatever is away is the side of rotation. So in this case, I will say that sir or ma'am, the X-ray is rotated towards left. Believe me, this is where most students get confused, that is it right or is it left, and what changes will it make. So we will remember simple thing, whichever is farther away, that is the side of rotation. So I'm going to say whatever is farther away is the side of rotation. I hope you just remember this thumb rule, you will not go wrong. So in this case, I'm going to say that the X-ray is rotated towards left side. Yeah, so that is why whatever side is rotated, once you've mastered this, then it becomes very easy. So now what will happen? It means that there is going to be more exposure of the X-rays. More X-rays are going to pass through the left lung. When I'm rotated towards left, more X-rays pass through that side. So what will happen? The left lung appears blacker. In technical terms, left lung appears hyperlucent, and also what you remember is that the left mediastinal structures appear more prominent. So what's going to happen is that the aortic arch appears more prominent. No need to memorize this. Once you know what side is rotated, those striate structures are going to appear more prominent. So here now what do I say in this particular X-ray? So I can see how it is rotated towards the right. So here I'm going to say that, sir or ma'am, the X-ray is rotated towards the right side. It's a right rotated X-ray, and that is why what we are going to have is more lucency of the right side hyperlucent may be seen. Secondly, what I may also have is the prominence of the right sided mediastinal structure. So the SVC will appear more prominent. So whatever is the side rotated, that side prominence will be seen, right? So this is the most important, is rotation. So we've assessed all of these things. So quick recap, you've been given a chest X-ray. What are you going to say? You're going to talk about the patient demographics, you're going to talk about the history, you're going to talk about prior imaging, and then you talk about frontal view, PA view, adequate penetration, adequate inspiratory effort, and non-rotated X-ray. This is how our normal Viva will proceed. Now you talk about the specifics. Now let's talk about a systematic approach to reading any X-ray. This is extremely important, because if you just look at the film and you go, this looks normal, and you go to the next one, you are going to miss a lot of findings, right? So this is what you have to adopt every single time. It may take time, it may be painfully slow, but it's something you have to do, otherwise we miss findings, right? So inside out approach is what I prefer, because it's simple and you don't have to remember any mnemonics of sort. You just start from the center and you move outwards. So in the center, the first thing you see is the airway. So you can see the trachea here, you follow it to the right and left side. The main thing is there any shift? Is there any shift of the mediastinum or the airway or not? So we look at the airway first, simple enough. Now we comment on the mediastinum. So for that, we need to know what constitutes the mediastinum on both sides. Or other way of putting it is, what are the cardiac structures forming the two sides of the mediastinum, right side and left side. And we'll also talk about the heart being the main constituent of the mediastinum, right? So let's talk about the cardiac silhouette now. So every X-ray, what you have to mention at least in exams is cardiothoracic ratio. What is the cardiothoracic ratio? So it's the ratio of the heart compared to the entire thoracic diameter. So for JRs, first year JRs, they'll ask you how do you measure it. So what you're going to say is, I draw a line joining the spinous process through the center of the thoracic vertebrae. Then I measure the maximum diameter of the widest part of the right heart, which is A. Then I measure the maximum diameter of the left side. So this is how I get A and B, and then I measure the widest thoracic diameter. So A plus B divided by C is what is going to be cardiothoracic ratio. So normally it is close to 0.42 to 0.5. These are really specific numbers. Basically, it has to be lesser than half of the entire thoracic diameter. In neonates though, it can be bigger, where it can be lesser than 0.60. Right, so 60% in neonates, 50% in normal adults is our cardiothoracic ratio. So first things done. Now we talk about what constitutes right heart border, what constitutes left heart border. So on the right side at the top we have SVC. Then the main constituent is RA and a very small part by IVC. So the right heart border is formed by SVC at the top, RA and a very small part of IVC, right? SVC, right atrium and IVC. On the left side, it is more important. So on the left side, the topmost part is the aortic knuckle, which is formed by the aortic arch, right? So this is the aortic knuckle. Then we have the pulmonary artery. Remember, between the aorta and the pulmonary artery, this is known as the aortopulmonary window. This has to be concave, otherwise you would expect some sort of a mass here. Okay, so this is the aorta. This is the pulmonary artery. So this is the aortic knuckle, as we like to call it. Remember, formed by arch of aorta. And this here is our AP window, which has to be concave. The normal constituents of AP window is usually fat, lymph nodes, and recurrent laryngeal nerve. The recurrent laryngeal nerve passes here. So the clinical importance is that if I have a lymph node here, maybe say a lymphoma, or I have a mass at the epiphyseal, maybe a CA lung, that can compress the recurrent laryngeal nerve, leading to hoarseness of voice. So that's the clinical counterpart here. Okay, so this is the epiphyseal. Then what you need to remember, what comes next is a triangular appendage of the left atrium, which is the left atrial appendage or the left auricle, and then we have the main left ventricle. So I have the left auricle coming in next. Remember, not the left atrium, the left auricle, and then we have the left ventricle. What forms the base of the heart on the X-ray is the right ventricle. Yeah, so these are the borders of the heart on a chest X-ray, and what I notice here is left atrium does not contribute to the formation of any heart border because LA lies posteriorly. Do remember this, that left atrium does not form any part of the heart border. So when I look at a lateral radiograph, we shall be discussing that as well. What you're going to notice here, LA is posterior. The anterior most part is going to be the right ventricle. So RV is going to be the most anterior heart chamber. LA is going to be the most posterior heart chamber. Right, so this is what we have learnt about the heart silhouette. So we've done the airway, we've done the mediastinum, we've talked about the cardiac silhouette. There is no abnormal bulge, there is no mediastinal mass. Now we go lateral and we talk about the hilum. So now we are talking about the hilum here. So when we talk about the radiographic hilum, I need to assess three things. One is the position of the hilum, whether it's normal or not, the density, and the branching pattern. Here, what I first want to talk about is again a theory question, which is favorite for the examiners, is what is the main contribution, what is the main constituent of the radiological hilum? The answer to this is going to be vascular. So first you start with the most non-specific answer, right? Lead the examiners to this answer. So tell them it's vascular contribution. So then they'll ask you which vascular structure. So then you will say pulmonary artery. So it is going to be pulmonary artery, which are the major contributors more than the pulmonary veins. Minor contribution may come from fat, it may come from lymphatics, and it may come from the bronchial wall. So this is what constitutes the density of the radiological hilum. So main is PA followed by P veins, and minor contribution from fat, lymph nodes, and bronchial wall. Okay, so now let's talk about the detailed arrangement of the hilum. Normally, which hilum is higher? Very basic thing. Left is always higher than the right hilum. So left higher than right. In around 5% of the population, left may be equal to right. But the rule you remember, the rule that I remember is right is never higher than the left one. If right is higher than the left one, you have to expect a pathology, and most commonly it will be in context of a right collapse. If there is a right upper lobe collapse, what will happen is the right hilum gets pulled up. So this is one of the signs that you look for, that if right hilum has been pulled up, you have to rule out a right upper lobe collapse, right? So this is about the position that we assess. Why so? Again, now we know the basics. So here, first of all, you can see how this is the pulmonary artery. So this is higher on the left side. So now let's look at the anatomical arrangement. Also will be asked a lot. Okay, so here on the left side, because it's the artery which is the major contributor, and left pulmonary artery is always higher than the right one. You can see it here in the figure. That's why the left hilum is higher. That's the basic thing that you remember. On the right side, we have the two bronchi, right? So the right upper lobe bronchus divides into the bronchus intermedius and the right upper lobe bronchus. So we are going to have the eparterial and the hyparterial bronchus here. So we have the bronchus higher on the right side. Yeah, so that's what you remember. And then you have the pulmonary veins. As far as anterior to posterior arrangement is concerned, it's always VAB as far as the hilum are concerned. So anteriorly, you have the veins, then you have the artery, and then you have the bronchi, veins, artery, bronchi, right? So this is about the arrangement of the hilum. So what we notice here is first the position, wherein the left hilum is always going to be higher on a frontal view. Density wise, they have to be symmetrical. That is what you assess, whether there is symmetry or is the density increased. If the density is increased or there is hilum predominance, one of the most common non-specific finding you will see reported is hilar predominance is noted without any sort of description. So that's not right. So whenever you see that the hilum is predominant, what do I have to say? Is it a lumpy bumpy sort of an orientation? Lumpy bumpy orientation meaning there is this rounded sort of a prominence, in which case you have to rule out lymph nodes, or there is no lumpy bumpy and what you see is that the hilum, the pulmonary artery, is very prominent and then it suddenly tapers. It is very prominent and then suddenly it tapers. So that is what we see in cases of pulmonary vascular hypertrophy or pulmonary arterial hypertension. So if you see that it is prominent without a rounded sort of a configuration, with this word being mentioned with tapering, then I have to say that it is PH, it is pulmonary arterial hypertension, which has been compared to jug handle, so it looks like the handle of a jug. So just gonna write that, not very important in practice. Yeah, so this is about the density. And then we talk about the branching. So branching again has to be symmetrical. Okay, we also talk about this V point. Yeah, so we can assess the position by this V point where the upper lobe, this is the upper lobe, and the lower lobe. The lower lobe pulmonary arteries, they tend to compare with little fingers. Yeah, not very important. But this V point is what we compare to assess the position. Yeah. Quick word on the lateral radiograph again. So we can see how the right pulmonary artery is going to be relatively anterior when I superimpose the two hila. So here when you see this is the right artery, this is the right pulmonary artery, and this one is the left pulmonary artery. You can see the two bronchi here. Obviously right is higher and then we have the left. So this is what constitutes the radiological hilum. So now after having assessed the airway, the mediastinum and the hilum, now obviously we go to the lungs. So this is something that I'm going to ignore for the time being. It's the main thing and we're going to do it in a systematic approach. So obviously you assess for any opacity in the lungs or any hyperlucency in the lungs, and it's going to be separate detailed lecture on that, about how you assess abnormalities, with the pattern approach, whether it's a confluent opacity or it's a reticulonodular opacity or a nodular opacity. We're going to discuss that in great detail. So we look at the lungs. After that, you look at the chest wall and the bones. So we do the rib counting here to look for any fractures, if you know that is a suspicion. Otherwise, you look at the continuity of the chest wall, look at the 2 CP angles. So the costophrenic angles have to be sharp on both sides, the right and left. So that is what you look at. Look at the continuity of the diaphragm. Normally, it's the right dome of diaphragm which is higher, because the liver pushing or the left side heart pushing it down, doesn't really matter. So right and left, the position of the diaphragm, right dome of diaphragm is going to be higher than the left one. Something that you tend to ignore is looking at the abdomen, even though it's a chest X-ray. And the most important thing here is to look for air under the right diaphragm, not the left, because left normally will have the gastric air bubble here, which is going to be normally seen. So we always look for air under the diaphragm on the right side. And finally, before you press submit in your report, what you have to do is make it a point to look at the 3 hidden zones that we tend to ignore. One is going to be bilateral lung apices. So the first one is the lung apex. Second is going to be the hilar area, frequently missed, even though we talked about in great detail. Third is going to be the retrocardiac area, so behind the heart if there is any opacity. And fifth is going to be the diaphragm, right? So if you see any opacities in the subdiaphragmatic area. So these are the 4 hidden areas which always make it a habit to look at. If you have it, in your residency, it will never go away. If you don't develop it now, it will never come also. Okay. So this is about the systematic approach. So just to recapitulate, we did the airway, we look at the mediastinum and the cardiac silhouette. We looked at the hila, we talked about it in great detail. You look at the main bilateral lungs, look at the chest wall, CP angle, diaphragm, abdomen, and then 4 hidden areas. So this is our approach. Now let's talk about the ribs. So whenever we talk about rib counting, so this is something that we discussed. What hack I used to use when I was a resident is that what looks like the first rib is the second rib. That was my rule here. So when we start counting, this is what I take as the first rib. No, so this is what you have to remember, that the first rib is actually higher up. So this is the first rib, the posterior part, the anterior part here, right? So first, posterior, curved, and anterior. So this is what I need to remember as far as the rib is concerned. So once you know the first rib, the second rib then onwards becomes very easy. So after that, it's all gonna be horizontal. It's the first one which is a bit curved here, right? So the one which I have completely drawn is the second rib. This is the first rib. So after that, the posterior ones are going to be very easy. That this is third, this is fourth, this is fifth, sixth, seventh, and eighth. So this is how you approach the posterior ribs. Talking about the anterior one, so I have the first, I have the second, this is the third one, this is the fourth one, this is the fifth one, this is the sixth one, this is the seventh one, right? So this is how you have to approach. So this is the same image showing here. So do not be confused by the clavicles. That has been colored separately for you. So 1, 2, 3, 4, and here you have the fifth rib for you, right? So this is how it works. Practice it a few times, you'll get the hang of it. So now let's look at this case that you have been asked a question of what are the ribs which have been fractured. So how do I go about it? So this is the first one, the second one. Once I do this, then my posterior job is going to be very clear, and you can see that it's going to be the posterior ribs which are fractured here. So once I know that this is the second one, then my third, fourth, fifth, sixth, and seventh becomes very easy. So this is the sixth and seventh left posterior ribs which have been fractured. So all you got to see is, go through every rib, and in fact, so what you've got to do is go through all the ribs, see for any discontinuity, look at the anterior posterior ribs continuously, and you'll find the fractures. You'll be able to label them adequately. Okay, so it requires just a bit of confidence and practice, and then you're going to be sorted. Talking about the importance of hidden zones, so look here, if you just look at it in passing, you're gonna say that it's completely normal. But if you go back to your hidden zones, if you look carefully, you see that, oh, there is some increased density here, and it actually turned out to be a malignant nodule in the basal zone. So we have the basal zones which are going to overlap with the diaphragm. So it is one of the hidden areas where we think there is no lung, but there is definitely the posterior basal segment which can have a malignancy, and you would have missed it. And this patient, who would have been operative, would have become, a really advanced case, and something you really don't want to do. So this is about the importance of the hidden zones. Something that examiners love to ask is are normal variants in spotters particularly. I just thought I'll compile a few of them and show it. So here in the first one, can you see how inferiorly there is a lot of prominent density? So these are nothing but the costochondral junctions or the costal cartilages which have become calcified. So this is the calcified lower costal cartilages. In the second X-ray, look here, can you see how there is a bifid rib? Yeah, so I will do them as spotters also, sometimes I'll mix them up and ask you, but right now I'm just showing it because it's a recorded lecture. So what you are seeing here is a bifid rib, right? So which rib is bifid? For that, we have to start from the top. Never take shortcuts. That is again one tip for you. So this is the first one, this is the second one, this is the third one, and this is the fourth one, right? So this is the fourth anterior rib which is bifid. So this is the bifid fourth rib. Look at the next one. Pretty interesting. If just looking at it in passing, you might think that there's some additional density here. Maybe it's a nodule or a mass. Look carefully again at the ribs here. So this is the first rib. This is the second rib, and I can actually see that they are fused here, right? So it's actually a fused first and second rib which is resulting in this additional shadow here. Okay, so two variants, two bony variants. One is a bifid rib, second is a fused rib that we need to be aware of. Next, something very common, and you have to pick it up because it can result in thoracic outlet syndrome. So you can have one side patient complaining of neuropathic pain, paresthesias whenever they do hyperextension or abduction. So that's the thoracic outlet syndrome. Rarely it can have subclavian vein or artery getting compressed, right? So that is the cervical rib. So look carefully here. This is the accessory rib, which is the cervical rib. So cervical rib may be bony. Most commonly, it is bony plus fibrous, and if it is completely fibrous, there is no way to pick it up on an X-ray. So in this case, we can see it's a partially bony rib here. So that's the cervical rib, accessory rib. Then look carefully here. So whenever I start my systematic approach, I'm looking at the airway. Next, I'm looking at my cardiac contour, and there I find that, oh, the left-sided aortic arch is missing, and what I have is a knuckle on the right mediastinum. So this is what shows a right-sided aortic arch. The next thing I always look at is rest of the structure. So I see that there is no dextrocardia. There is presence of the fundus in the normal position. So there is no situs per se. It's only right-sided aortic arch. And if they ask you what would you do next, I would definitely want to do an echo in this patient because it's associated with a lot of congenital heart diseases, right? On the other hand, look here. So here I see the right label, but the heart is pointing towards the right side. The fundus air bubble is on the right side. So is this Cartagena syndrome? Is this situs inversus? So remember that labeling errors in the world are far more common than people with situs inversus. So higher likelihood that this is actually a labeling error by the technician than actually this being a case of situs inversus. But then how do I solve it? So remember how we are radiologists, but we are also doctors. We tend to forget this at times. We do have access to the patient in addition to the X-ray. So what you just got to do is call the patient and auscultate whether there is, don't even auscultate, you can actually palpate for the maximal impulse, whether there is actually dextrocardia or not, right? So this is how you can actually know whether it's dextrocardia or not, is by seeing the patient. If you're not confident, call a medicine GR up, call a friend and confirm. So in such cases, before I report it as situs inversus, I got to be sure that it's not a labeling error. Very, very important, because nobody else is going to do that, right? Your medicine GR is not going to think of a labeling error. If you reported a situs inversus, this patient gets worked up for Cartagena syndrome, for other causes, and might even get a CT scan, which was actually not needed, So extremely important thing that we have to remember here. 3 more cases that I want to look at. So look at this one here. You can see that there is this fissure on the left side. A left horizontal fissure is something we don't expect. So this is what is an accessory fissure. This is also where, sometimes your viva can take a turn. They can ask you about the different accessory fissures which are there. So this is one of them. One very important, the most common accessory fissure that we have, you always look at the right upper zone, and this is the azygos fissure. So azygos fissure forms this accessory azygos lobe, and the clinical importance is that I can have an azygos lobe consolidation. So this is an azygos lobe consolidation, and this is one of the very common spotters that I've seen in the exams, right? So this is something that you just have to write as azygos lobe consolidation. All right. Finally, we talk about the lateral view now. So lateral view, in my opinion, is a very underrated tool. If I see some abnormality which is very equivocal on a chest X-ray, most of the times the patient will, in practice, end up getting a CT done to confirm. But what is something that we can use and we have as our armamentarium is the lateral view of the chest radiograph, which is very underutilized. So what are the various indications where you can actually make it a practice to do lateral views? One, to confirm any equivocal opacity, which can, be confirmed on a lateral view, whether it's there or not. Localization. So on the frontal view, obviously it's a two-dimensional thing. There's going to be overlap. So if I want to confirm whether it's the middle lobe, upper lobe, lower lobe, lateral view view is going to help me do that, and the hidden areas on my frontal view can be better visualized here. So we can perfectly see the retrocardiac area. I can see the hilum here opening up, and I can see below the diaphragm. So it gives me a different perspective. So like that case of a spiculated nodule in the posterior basal segment, if I'd done a lateral view, I would definitely have seen a lesion here, right? So this is something which are the common indications. So this is how a normal lateral view is acquired. Normally you would want to have the limbs, if the patient is healthy enough to do this, you want the limbs to be elevated so that the scapulae can go out of the field, right? So here you can see the two scapulae. So if it's not elevated, we might see that projecting into the field. Otherwise, it will be almost off the field. So that's what is ideal. Okay. So this is how we acquire the lateral radiograph. Now let's look at the checklist, right? Before we look at the checklist, this is a schematic of what a lateral radiograph looks like. So let's just go through it. So here you can see that these are the spine, right? These are the vertebrae. I can see the heart here. We have already seen how RV is anterior and LA is posterior. This is the aortic arch here. Now let's talk about the airway. So this is the trachea. You can see the two bronchi. So these are the two bronchial air shadows that we can see here. So in the X-ray, you can see this is the trachea here, and we have the two air shadows. And as we saw about the hilum, we've already done that. It's the right anterior one, and this is the left posterior one, right? We talk about the hilum. So first we talk about the arteries. So this is the right pulmonary artery, left pulmonary artery. These are going to be the shadows, opacities. The airways are going to be lucent. So it's the right airway which is higher, the left one being lower. So right is higher and anterior, artery and bronchus respectively. Then we talk about the diaphragm and the fissures. So look at the fissures here. They do ask you to identify. So in this case, what you have to remember is the more anterior one is the right oblique fissure. So this is the right oblique fissure that we are having. So what you can see, so this is the left one and this is the right one. The left is a bit higher, but it ends more posteriorly. So it's the more vertical one. So left oblique fissure is the more vertical one. They ask you the surface marking. So this starts from the T4 vertebrae, right? So this used to be a very common Viva question in AIIMS. So what they used to do is they used to tell us to draw. So what the only word they wanted to hear is T4. So what you have to say is that left is more vertical, right is the one which goes anteriorly. So it acts like two propeller blades. That's how it's described in textbooks classically, that it's like two propeller blades. And obviously we only have the right horizontal fissure. So it starts with the oblique fissure and goes horizontally around the fifth costal cartilage. So this is the right horizontal fissure. Important is to talk about the diaphragms here, right? So now we talk about the checklist. So we talk about the diaphragm. So the diaphragm here, they will ask you to draw which is right, which is left. So what you have to remember is the right is the one which I see throughout. One diaphragm which I see throughout is right. In this case, you can also see the liver shadow here, right? On the other hand, the left hilum is what I will see till here, and then because of the heart merging into it, I will not be able to trace it further because of the silhouetting, right? So here you will have to trace the right and left one. What you say is that the right is continuously traced, whereas left will not be traceable. So this is diaphragm. We talked about the hilum. So any density here, any lumpy bumpy shadows will be better appreciated. Fissures, we already talked about how to mark them. I can also assess the anterior and posterior costophrenic recesses. That way I can detect pleural effusion more sensitively than I would on a frontal radiograph. I look at the heart. We already know how the chambers are arranged. Very important, two signs. One is retrosternal lucency. So this is something that we always look for. If there is no lucency here, this blackness here is not there, two things you have to rule out. One, it could be a right ventricular hypertrophy. Second, it could be an upper lobe, right upper lobe or a left upper lobe opacity, consolidation or collapse which can occupy there. Second is the spine sign. So what happens is, because there is more lung overlap in the lower areas, we see that the spine appears better as I keep going down. If that's not the case, if I see that there is obliteration or blurring of the spine inferiorly, there's definitely a lower lobe consolidation. So the spine sign helps me in picking up a lower lobe consolidation, because the spine appears more and more better as I keep going down because of more lung being normally present. So more X-rays can pass through it, and the spinal opacity, the vertebral opacity appears better. So these are the certain points that they ask you from lateral. Why this lecture is very important is because this is your building block in your first year, or maybe sometime in your final year also. One of the cases is frequently a mediastinal mass, or a chest x-ray case, and that is what scares most students. That is what used to scare me as well, that chest x-ray na hai, baki sab kuch we will handle. So this is something that will solve a lot of your problems if you go back to this class even very close to your exam. I think it will solve a lot of your approach based questions, and it will set up the tone for your viva, like I said. So all the very best. I hope you enjoyed this. Thank you.